Good evening. Welcome to Stories from Sullivan. I'm Jim Alatris. I'm the president of the Rockefeller Institute of Government. Man, that makes you a little emotional, doesn't it? First of all, I want to give a big round of applause to Kyle Adams, our communications director, for putting together that video. It's going to be released so a broader community can see it, as well as all the photographs out on display. Let's give him a big, giant round of applause. Part of it's capturing the human element. Often in social science, we talk about numbers as if there's not people behind those numbers, but it's ultimately about community. So Kyle did that magnificently, and I'm really glad and happy that he was able to participate in the project. First, a couple of things. Rob Kent from the state, who has been working on fighting addiction, no matter what it is, for decades, is here tonight. Rob, could you just stand up and let everybody know you're here? And let's give him a round of applause, wherever he is. Rob Kent. He's one of those tireless people in state government that you don't often think of. Everybody often thinks about bureaucracy and things, but he is truly an advocate for making this world a better place, and we're glad to have him here. I want to thank our research team, led by Patty Strock, who's our director of policy and research, and soon to be the interim me as I move on. It's big shoes to fill, and she's not going to fill them, but she'll try. I'm kidding. She's going to overfill them. Patty Strock, Katie Zuber, and Elizabeth Perez-Chiquez, they literally put their heart and soul into this project. More than 18 months, spent a lot of time in Sullivan County. My wife and I are from Sullivan County, Ulster County. We love it down there, but some people are like, I have to go to Sullivan County? Why Sullivan County? And they really deserve a lot of the credit for doing so much important research. So let's give them a big round of applause. And then you on the front lines who are living with this, dealing with this and fighting back. We call this fighting back because we don't believe in passive, just looking at a study. We like people who are going to rise to the challenge. So give yourselves a big round of applause for all that you do every day to fight this epidemic. We're going to have presentations of our findings by Katie and then a panel discussion. But before that, I just want to make a couple of opening remarks. Tonight really is a celebration for a community that is fighting back with something that seems is a seemingly insurmountable challenge if you think about the crisis that we're facing, especially on opioids. We talked about this a couple of years ago, and what we noticed was policymakers kept putting more proposals out there and doing more and more. And as they were doing more and more people were dying. So something wasn't working. So we really wanted to go into a community and figure out, how do we address this crisis? This isn't a typical research project for any SUNY organization or college or research university or research center like we are at the Rockefeller Institute. And this is probably one of the most challenging projects that we've ever taken on here. And we call it research in real time. We didn't know what we were going to get. We didn't know how it was going to come out. And we were going to present it as we were doing it, which is a little scary because you could also be wrong as you're going along. But I think that was the challenge we wanted to do. Usually social scientists, they spend years developing a hypothesis, getting test cases, and then they say, give us 5 or 10 years and we'll give you an answer. Well, we don't have 5 or 10 years to try to figure out what's going on. Action is needed now. And then there's times where I've heard people say, you're really taking this project personally as you're following with Patty and Katie and Elizabeth as you're watching it, and you seem a little angry about it. Well, damn right I'm angry about it. We all are angry about this. And what the question is, how do we challenge that anger into action? How do you do something about it together? And that's why we're here, and that's how we'll do it. So tonight, it's all about you, especially who have come from Sullivan in the community. This is a celebration for you. This is also to thank you for allowing Patty, Katie, and Elizabeth into your homes, restaurants, community centers, police departments. They were everywhere. I'm sorry if they were everywhere, but that was part of it. And most importantly, your lives, because hopefully the findings that Katie is going to go through in a minute, this discussion will lead to a better result where people have a chance to overcome whatever troubles they're facing in a way that isn't addiction, and that we solve this opioid crisis. So with that, thank you. And I'd like to turn it over now to Katie Zuber to go through the findings of our report. Thank you very much.
Thanks, Jim, for the introduction. Thank you all for coming out here tonight. I also want to just say thank you again to our communications department under the direction of Kyle Adams, not just for putting this event together, but for really capturing this project in a way that I think helps people who don't live in places like Sullivan County understand what it looks like and who the people are that are living there. You know, as Jim mentioned, we know that the statistics are alarming. So of the more than 70,000 overdose deaths in 2017, more than 47,000 of those involved opioids. We also know from the research that opioids have a disproportionate effect on rural communities, but it's not necessarily always clear why that is. So if you read the headlines, they often warn about deaths of despair. Many of you have probably heard this concept before. It's this idea that things are so bad in these communities due to unemployment, due to poverty, due to health disparities, that people are turning to drugs and alcohol and suicide with increased frequency. But deaths of despair really don't tell us very much about why some people in rural communities turn to opioids while people in similar situations do not, or whether and to what extent despair is also caused other past drug epidemics like crack cocaine or heroin. So while it's likely that despair plays a role in all types of addiction, there has to be some kind of mechanism that is going to link despair specifically to opioids. And you can kind of think about this idea that high rates of rural drug use are caused by despair is similar to this 19th century concept of miasma, or this idea that bad air was responsible for the spread of cholera and yellow fever and other health epidemics. Even though the stench hanging over these early American cities was real, these particular diseases had very specific causes, like bacteria and viruses, and they were spread through very specific mechanisms, either contaminated water or mosquitoes, for example. So in a lot of ways, we can think of despair as being like miasma. It's this black cloud that's hanging over a community, but it's not a black cloud that's actually causing the epidemic. Again, there has to be a very specific cause and a very specific mechanism through which opioids spread through communities. So to kind of gain a better understanding of both the causes and the consequences of the opioid epidemic, we used what we call a method of listening. And as Jim had mentioned during his remarks, this is a little bit different than the traditional social science approach to doing research. So we didn't have any predetermined list of questions that we wanted to ask people. We didn't go down with a specific list of people we were going to talk to, really. We talked to anybody who would sit down and talk to us about what they perceived as being a problem. And then we took these interviews and we combined them with the aggregate data to get a more clear picture of how opioids affect local communities and what state and federal policymakers can do to get a handle on the problem. And so this data suggests that alternative mechanisms to despair, including access to prescription opioids, may actually hold the clue to some of these current health disparities that we are seeing. So, for example, we know that white Americans have higher opioid overdose death rates relative to Hispanic and Black Americans, but we also know that white Americans have greater access to health care, as well as greater access to opioids within the healthcare system. We also know that prescribing rates are much higher in rural communities than they are in urban communities, and yet access to providers is the reverse. Sullivan County is actually the exception to the rule, but most rural communities throughout America do not have access to a single prescriber of medication-assisted treatment. So in a lot of ways, Deaths of Despair is this really effective soundbite, but it distracts us from the primary causes of the opioid epidemic and some of the underlying conditions which make it difficult to treat. In a lot of ways, you can think of New York State as a best-case scenario. It has more public treatment options than most other states throughout the country. It has a dedicated agency for addressing substance use disorders, the Office of Alcohol and Substance Abuse Services. But for all of these advantages, we've heard from people on the front lines about the different barriers that are put in place that make treating substance use difficult. So, for example, under the medical model of care, hospitals will require individuals to undergo physical withdrawal before they're admitted to detox. Oftentimes, the symptoms of withdrawal are characterized as flu-like symptoms, but as one person in recovery pointed out to us, it's more like the flu times a million. Making people undergo and wait to undergo that very painful experience of physical withdrawal can mean that people will actually walk out before they get the treatment that they are asking for. We say that addiction's a disease, that it's a treatment, that it's a condition that requires expensive medical treatment and personnel like doctors and nurse practitioners, but community providers are not being paid enough to cover these medical costs. So we actually spoke to one provider in New York City who said that they recently were awarded a $2 million federal grant from the federal government, and the only thing that the federal government wouldn't pay for is a $300,000 salary to hire a doctor. So if we want to treat this as a medical condition, we need the medical professionals who are going to be qualified to do that. The demand for these services is really high, but local communities have to deal with a nationwide shortage of the medical professionals and personnel that are necessary to treat addiction as a disease. So again, less than half of all U.S. counties have a physician who can prescribe buprenorphine. And again, it's not just prescribers of medication-assisted treatment that are missing. It's physicians, it's CASACs, it's nurses, it's social workers, mental health providers. Federal rules and regulations can, federal rules and regulations can actually exacerbate this problem. So under the existing system, it's actually easier to prescribe opioids than it is medication-assisted treatment. So buprenorphine, unlike something like methadone, for example, can be prescribed in a physician's office, but practitioners have to obtain a DEA waiver before they can do that. So that basically includes an 8-hour training for doctors and an additional 16 hours of online training for physician's assistants and nurse practitioners. In addition, on the limits on who can prescribe MAT, there's actually restrictions on how many patients they can treat. So during the first year of buprenorphine certification, physicians can have up to 30 patients under their care at any given time. After a year of certification, they can apply to have that number increase to 100 and then eventually to 275. Certainly, there's a need for accountability and there's a need for oversight. Medications like Suboxone should not be prescribed in the absence of intensive behavioral and mental health counseling. But despite the risks, there are no comparable restrictions for practitioners who prescribe opioids. So substance use is really a major concern for both rural, urban communities alike, but our rural context presents some unique challenges to being able to address this particular problem. Public transportation is limited. Agencies have to provide aftercare and other wraparound services to a remote population that is spread out across a wide geographic area. So we always like to tell people who aren't from Sullivan County that it's the size of Rhode Island. Safe and affordable housing can be difficult for people both in and out of treatment to come by. And even though local governments and the community didn't necessarily create this problem, they lack the capacity to be able to address their problem strictly on their own. So what can state officials do? We have heard that providers and the community are doing everything they can with the minimal resources that they have. coming in on weekends on their days off to repair and to paint facilities, building gardens, and organizing softball teams, because something has to take the place of drugs, even though these are activities that are not reimbursable under existing protocols. So the community is really doing everything that it can to get ahead of this problem, but they can't do it alone. Policymakers really need to patch the holes that are left in this system of addiction treatment in New York State, and they need to be able to create comprehensive programs and policies that are going to meet the needs of these particular communities. They can think about standardizing protocols for treatments with substance use disorder, and so much the same way that a patient presenting with chest pain would be met with a single standard of care, so too should a patient who presents with the symptoms of opioid addiction and withdrawal. Help providers meet their staffing needs. So if treatment beds are available, but there is no receptionist to answer the phone or a clinician to do an intake, that bed may as well not exist. So it's not just about increasing the number of treatment beds, it's about incentivizing people to get the required education and training, getting people to take a job, and encouraging them to stay in it. Also thinking about correcting the imbalance between prescribing opioids and medication-assisted treatment. So one state official put it this way: if you want pills, all you have to do is limp into the ER and say your pain is at a 7. But if you want methadone, it's regulated as if it was weapons-grade plutonium. So again, medication-assisted treatment should not just be prescribed willy-nilly, but it should also not be easier to prescribe opioids than it is to treat opioid addiction. And I think the thing that Patty and I most surprised us, we would ask people, was always our last question, what is the one thing you would need from state policymakers to help you get a handle of this problem? And of course, you would expect that the answer would be money or resources, but almost always the first response was to listen, right? Of course, money would be nice, resources would be nice, but they want people in high positions to understand them and to really understand the problems and the challenges that they're facing in their communities. And so when we look at the statistics, it's really easy to blame deaths of despair, to buy into these stories of anguish and hopelessness as explanations for the opioid epidemic. The deaths of despair narrative really obscures the mechanisms through which opioids are spreading through communities, and it really erases the community response. So people in these communities are not rolling over. They are not throwing up their hands. One provider said to us, I don't care what the statistics say, we don't have the privilege of being able to give up. I know that the work that I do makes a difference. So as Jim said, providers in these communities, they are not dealing in terms of statistics, they're really dealing in terms of people. And so charts and figures are really informative, but they do not capture the on-the-ground struggle and response that we are seeing in these communities. They don't tell you about the parents who spearhead a public information campaign or moms who organize Narcan trainings. They do not tell you about local residents who tend a community garden that once used to be an open-air drug market, or about providers who have dedicated their blood, sweat, and tears to saving just a single life. So tonight is an event that is really designed to push back against this deaths of despair narrative and to celebrate a community that is really, truly fighting with every fiber of their collective being. So thank you all for being here, and with that, I'm going to turn it over to Patty and the real people of the hour who you all came here to see. So, Patty.
Thank you. So I'd like to invite the panel up here, and I just want to. So panelists, come on up. And tonight we're focusing on the grassroots response. So these are people who have day jobs, who have other responsibilities, and who do this on the side and at night and in every waking hour that they can get. Okay, sorry. But before we get started with the panel, I do want to acknowledge the folks in the room who work on questions of opioids day in and day out. And once we lick this problem, they'll do the same for the next problem that's coming up. So we have treatment providers are here. So Dynamic Youth Center in Fallsburg is here. We're the folks from Dynamic Youth Center. coming up here today. Catholic Charities of Orange, Sullivan, and Ulster is also here. I'd like to give them a round of applause. Because once we go home, they'll still be at this tomorrow, still be working on this. I'd like to also thank all the people in this room who shared their stories with us. I just want to say it takes a lot of courage to talk to two strangers who come and put a microphone and a tape recorder down and talk to you and tell them your story. So I want to thank all the people in this room who shared their stories with us. There's a great panel here, and I'm going to just say a couple of words about the panel. There's a nice biography written on everyone that you can read up on. But today we have Martin Calavita, who's the president of Engine and the chair of Sullivan Agencies Leading Together. Martin, you want to raise your hand so we know who you are? We have Sandy Oxford, who is a citizen activist. We have Guy Farina, who's detective sergeant in the town of Montgomery in Orange County, and who is the liaison for Hope Not Handcuffs. We have Barbara Greff, who's the co-founder of the Kingfisher Project, which you saw at the beginning of the video, and Annette Kars, who's the founder and president of the Tri-County Community Partnership and the director of Hope Not Handcuffs. Some directed questions for them. So, Guy, Detective Sergeant Guy.
I go first, all right.
Have you ever seen anything like the opioid epidemic before, either a problem of this magnitude or the kind of response that we've seen?
So, first thing that came to mind was a little bit apples to oranges on its face. So, also what I do is that I work with at-risk youth, and I've dealt a lot with teenage sexual assaults and domestic violence. And really, the first thing that popped into my head when I heard of this question was really that. And it might, some of you in the audience might be thinking, like, well, how does that even compare? To me, in my world with the criminal justice system is equally equipped to handle addiction as it is to handle sexual assault and domestic violence. In that, it's really not. You know, we can go down rabbit holes and talk about gender bias and implicit gender bias, but I won't. What the commonalities that I see with the big problem is both issues of addiction and sexual assault, domestic violence, even bullying. You know, they're very hard issues, they're very emotional issues. A lot of people don't want to deal with them. And like I said, our justice system's really not set up for it. But they also show a lot of commonalities in between it. Society is really not ready, even though they're starting to really deal with the addiction part of it. Sexual assault and domestic violence are really no one wants to hear about it. They don't want to deal with it. So that's really what popped into my head, was that issue and how prevalent it is and how unknown it is at the same time.
So I think it's a bit reminiscent of my experience growing up in the late 70s, early 80s, especially in the early 80s when we saw the crack epidemic hit. And it was a very different reaction. At a state level, we were very reactionary, and it spurred the prison expansion, where we had one of the largest prison industrial complexes in the United States. And I am hopeful that we are looking through a different prism at this stage of looking at this addiction, where it is less looking to incarcerate people and hopefully looking to put sick people in places where they could recover.
Marty.
Yeah, I agree with Sandy. You know, when I grew up in the Bronx, and I remember it being an absolute crisis growing up. And the only thing that was stark to me through the years is how the demographics have changed, and that, you know, it moved to kind of Midwest and middle class America. But I do remember, you know, the bodies. I do remember the hopelessness in Harlem and the South Bronx and Brownsville and Brooklyn. You remember, you know, that this stuff was ravaging our communities for a lot of years. And so I do see, I've seen it before. I don't want to see it again.
I think we all share that.
I think, to kind of piggyback off what you say, you know, from my perspective, you know, how many people think they can that we can arrest ourselves out of this problem? You can't. It's just not possible. Police officers have two choices when they come across someone who has drugs: arrest or release. Neither is helpful. So, you know, part of what the next step is, and it's a term that I like to refer to as advocacy policing, where we're, you know, kind of the new age of policing is engage in the community, actively take part in law enforcement, and the law enforcement be actually a part of the community, and that's through diversion. So instead of, you know, the only option being arrest or release, would be a third option to deflect the person away from the criminal justice system back to society where they can get the help, and that's kind of the goal, and hopefully where law enforcement can go.
Sandy, can you tell us, you know, Guy just said, you know, policing has changed. Who should be at the table when we're talking about this problem? Who should be at the table when we're talking about addressing opioids?
So I feel that it's important to have a holistic approach to facing this issue in our community. And often there are some of the more prickly personalities in the community, maybe like myself, who generally will challenge the status quo and who will speak up, get a bad rap in a small rural community. And people have very long memories in a small rural community. And I could probably write the urban person survival guide to living in a rural community, because I've made every mistake in the last 31 years of living in a rural community. That being said, I think it's really important. In my rural community is a very diverse rural community. And we have to be sure that we begin, every time we start things, that we start things with a reflection of what the community looks like. Because there are stakeholders that may not necessarily be formal stakeholders. They may not be, you know, the sergeant. They could be someone else who is the activist, who is the meddler, who is the natural mediator in your community that often shows up when things go wrong to try to help along the way. So I think it needs to be a combination of the formal and the informal supports within our community that is reflective of the community.
And how do we get people involved?
Ask them. Ask them to get involved. Am I on? I think I am. I don't know if you can hear me. There we go. I think just ask them. I think, you know, what I've experienced is a tremendous amount of community support and wanting to be involved with very little effort getting the people who've been affected, who have skin in the game like no one else, to step up. And I've seen it a lot, and along the way, working with people who are community members who want to do something, yeah, you're ruffling a lot of feathers. I can relate. I've definitely ruffled some feathers, because I think when we ask why or why not, it's not, sometimes they don't want to hear it. You know, I shouldn't say they, but you know what I'm saying. It's hard to get everybody that's the whole at the table thing. I think everybody should be at the table. You know. So.
Yeah, I tend to refer to that as kind of a community-based system of care, and I think that's probably, in my mind, the best approach. Kind of, I always picture kind of this picture of like all the hands in together, kind of supporting one another, or like a village raising a child type of a deal. You know, police departments, community, schools, churches, everybody kind of have their own, you know, hand in and dealing with this. And I don't think it's really hard getting the community involved. The community is more than willing to get involved. It's kind of when you get a little higher up and then the groups kind of start to segregate into, you know, different funded groups is when you kind of get the hair pulling and really trying to pull everybody back into the same cause, which we all have. But as far as the community is what's pushing, at least our experience.
Marty?
Yeah. There isn't a single person in this room that hasn't had experienced a time in their life where they felt lost, where they felt hopeless, where they felt like there was nothing that could help them at that point in time. It might have been something that happened to them, it might have been something that happened to somebody they loved, all right? And that's one thing we can all connect with. I know I can. And when I felt my most hopeless, I felt completely and utterly lost. And what brought me out of that hopelessness was the obvious, hope. And that was somebody touching me, connecting with me, and making me realize that I'm not in it alone, and that together we are absolutely better. Okay? So to get people at the table, I agree with the officer. It's really easy. Gus, not the officer. Gus, right?
Guy, Jesus.
You can call me Gus, it's fine.
But if we can connect with that feeling, we'll get people at the table. I also identify with what Annette was saying, that sometimes the people we don't want at the table sitting up here is the county governments. And I'm not saying this to put anybody down, all right? Is because they get in the way of that connection. Not them, but the process. There's nobody intentionally doing this. But there's this institutionalized dysfunction that develops a disconnect between the common man and the people that are sitting in the county legislature, at all the county seats. And that grows bigger as we go further north to Albany. And no offense to Rob and everybody here. But that disconnect is real. And that disconnect affects everybody. And that disconnect is responsible for hopelessness. All right? So how do we get people at the table? Very, very simply. Leave the silos, leave the politics to the side, and get in touch with that feeling that you had that time in your life. When you were so lost, man, that you would have done anything to feel hope. That's how we'll get people, and that's how these guys get people to the table. All right, so, I'm sorry.
I'll just throw in a word there about who should be at the table. Is the people who we have at the table the least, who are those who've been either actively using heroin or an opioid now, or just recently are out of using. And it's not that hard, but I think we tend to look all around that person and have those folks at the table, but we don't go into the center. And you know, I was at a meeting the other day with Marty, and he had a young man from the high school who was there, it was brave on his part. He's there. I don't know if he was an active user, but he was recently out of using, and it was a task force. It was, you know, official type people there, but that young man had the most valuable input in my book. So those are we tend to say, well, they might be in the rehab, but go to rehab. I mean, I know Dynamite Youth Center let us in that rehab, and we learned a lot.
Can I just say too on that? I just want to, because I agree with you, and I also, sorry, me and microphones. This one. I also think that addiction is a family disease, and we all know that. And I think that not only the person that's affected, but the family members who are affected. I mean, I can tell you that any mom or dad who has had a 20-something child of theirs that has been struggling with this problem either is in recovery or is currently struggling or has unfortunately lost their child, who has put their child in and out of different rehabs 10, 12 times, made phone call after phone call after phone call from their kitchen table. I mean, that's a really valuable resource, even as much as the person who is struggling, because they're the strength that keep that family unit going. So, and that's what we see a lot of are the family members, the siblings, the parents, the community members. So,
Annette, what's it like getting involved in a small rural community? Like, what has the community response been? Have you received pushback? Have you received support? And can you tell us what it's like to get involved in communities like yours?
So I'm kind of on the border of, I live in Sullivan County, but on the border of Orange, and we sort of intersect where Orange, Ulster, and Sullivan come together. So we have all of Orange's plentiful resources there. And community involvement, tremendous. If nothing else, that comes from my experience. And it's even difficult to say it, but it's an incredible demonstration of the human spirit and human heart. Because since we launched our program in January, and as of today, We have 373 volunteers who have stepped up to become an angel. 373. And I have to say, I'm not a magician. It's just people who want to help. We ask them to give us 1 6-hour block a month. That's it. And it's been great. So some of the pushback that I have gotten is that because of my coalition work, I am on a lot of different committees and things, and I do feel a sense of, without sounding negative, I do feel a sense of, oh, that's so nice what you're doing. You know, that's so sweet. Yet, because we don't have some type of federal funding or some type of grant, we do feel that we're not welcome a lot at the table. It's sort of an intangible feeling, but it's a feeling of, Marty's down there shaking his head. I mean, it's just, it talk about silos, and I go to these, I don't want to sound like I'm offending anyone, but I go to these community, county meetings, and I listen to them all talk about their grants, and they're doing this, and they're doing that, and everybody's, doing something. Yet, I don't know if there's a disconnect, but so many people are out there just wandering around. They don't know where to go. They don't know what to do. They're hopeless. They're parents who are just lost, and that's what I'm seeing. So I don't know how it gets lost between that and down where we are, but it's definitely an issue. So community response, amazing. Pushback, definitely. Sorry. And
the kind of kicker and the part that's very frustrating is when you look in Sullivan County, and actually Tom Boskett's the chair of SALT, not me. So we did a similar thing. We started a coalition in the county. So we developed a telephone number that if you call this number, 6 phones ring at once, and that's the SALT Steering Committee. So we get referrals from the agencies that Annette's talking about to this unfunded coalition is getting referrals from the agencies with the $1 million grants. And they're sent to us to provide a compassionate plan of care to get somebody into treatment, all right? And we won't give up. When I say we, I mean them. Won't give up. So when we get that call, we don't just say, go here tomorrow. That person is important to me as my grandchild is, and my grandchildren are. And I'm going to treat that person like my grandchild, and I'm going to walk that person to where they have to go, no matter what it takes. But just bear in mind that the agencies that are minimizing Annette Carr's and the works, I'm sorry, Barbara, and the work she's doing are the same agencies that refer people to her. An unfunded coalition.
I think, and I've referred,
And me.
I've said this a couple times in many different venues, but no matter how much good you want to do, no matter how much good you do, no matter how much good you guys do, there's always someone that stands up and gets in the way. For some reason, I don't know if it's human nature or not, they just want to get it in the way and be an obstacle. And I think the advice I can give is just keep going.
Yes.
Push them until they get out of the way and just keep going, because the community is going to be right no matter what. It doesn't matter how big the government's going to be or the organizations. Community can make things happen, and the more we work together, the more we can force what we want to happen.
I just want to say one thing too. I think Amy Kolakowski was her earlier. I don't. Amy was the person that she said, community involvement creates a cultural shift. And I'm sure you've heard that before, but I had never heard that term before, or that the way of putting it. And I believe that more than I've ever believed anything before. I just believe that if we don't all get involved, that's moms and dads, and we talk about community a lot. In all these meetings, we talk about community, the community, but the community's not there. We're the community. So don't be afraid of a new way of thinking outside the box a little bit, about involving community organizations and people who step up and want to give of themselves. Because, by the way, none of us are getting paid anything. You guys understand, as volunteers. So if we don't get everyone involved, I just don't think we're going to ever climb out of it.
Barbara, can you give us a sense, so we've heard about what the community is like and the challenges of getting community involved and being accepted for what you're doing, but can you tell us a little bit about what it's like to be involved in a rural community, to get involved in a rural community, and maybe some of the challenges? Katie talked about challenges, we heard about transportation. What are some of the challenges that you see in your rural community?
Well, I think you did a very good job in your research, and Kyle in the video, of portraying what Sullivan County is like in many ways. It's a big area to cover. People don't have transportation. They don't, something as simple as a car. We were talking about this at lunch today. You don't, even if you have a car, you might not have money for insurance. You might not have a job to pay for all the costs that go into that. And without those sorts of resources, you're finding yourself in this kind of void of where you can't get help. And I think that's one of the biggest challenges of the rural community, is that you just can't get there from where you are. You can't get to the doctor appointment without taking a half a day to get to a 10-minute doctor appointment. You can call the Medicaid transportation van, but by the time you come back, your day is gone. You can't have a job and still do that. You're up against a lot of challenges in the rural community that you might not find where you can get on a subway and go over to Columbia Presbyterian or someplace like that. So that's really it. It's like reaching the services that you need. And then I think also just the poverty or lack of opportunity that exists in too many of the rural communities that we have. And there's a lot of reasons for that, but when someone is trying to not be addicted, one of the first things they need is this concept of aftercare. They need a job. Where are they going to get it? Who's going to help them get that job? Maybe your parole officer was on your case about getting a job, but did they help you get it? And do they even know how to make those connections for you? So those are the challenges, I think, and there are many that are in the rural community. We, because of the Kingfisher Project, I think had a very unique advantage on it, because just about everybody can listen to a radio. And it helped to bridge that distance that we all feel. We have people from all over the place get on our radio, because you can pick up the phone and be our guest and tell us what you're, like Mr. Kent's going to be later, I think in July. And you can be on our airwaves, and then you can reach an audience that you don't have to be in the same room with. It's the precursor of the internet, if you will, radio.
I just want to add to that, because I feel in our community, the Kingfisher, the brain trust of this group was really what created kind of like the platform, what I would say the initial platform for having the community-wide conversation about opioid addiction in Sullivan County. And it was maybe the beginning for trying to delete some of the stigma, and just beginning with that conversation about deleting stigma, and also kind of putting some of the elected officials' backs up against the wall, because now the media is here, they're listening to it, this is a community-wide dialogue. What are you going to do as an elected official? What are you going to do as a person with power now that we are all listening? So that was something that a lot of people did not have access to, because they didn't have a car, because they couldn't get to the outskirts of the community, but you could turn on the radio. So social media, radio, those things are very powerful in rural communities. If you have broadband, which is another issue.
Thank you, Sam.
So everyone featured in the video that you saw is doing their work on a shoestring budget, often coming out of their own pockets to pay for the kind of work that they're doing. So what kind of resources do you need to continue doing the work that you're doing?
I think, first of all, the most beneficial commodity that we could get at this table is hearts and minds. Is people to realize that we need resources. And of course, funding would help everybody at this dais. That's the word. We need support. More importantly, we need hearts and minds. We need people to realize that every single solitary person who's in our community is a stakeholder. All right? So we did something similar recently where we did focus groups and key informant interviews. And because of Barbara Greff's input, we went to the homeless. We went to the people who are currently, suffering from substance use disorders. We went to people that are living in abject poverty and are truly hopeless and interviewed them. And the one constant, there were several constant threads, but the one thread that was incredibly powerful was support. People did not feel supported. The families who were suffering because of stigma, the person who's suffering from the disorder, him or herself because of stigma, the loneliness. I had a fellow tell me, Marty, I never thought I would die in Sullivan County, because for me to get an answer from DSS, I have to walk 7 miles, all right? Because medical transportation isn't going to take me there, all right? So, yeah, we do need funding. We need support. And I guarantee you, this doesn't take a lot of intelligence, because just notice I even have one of my socks on inside out. So that's how right you got to be to do what I do, But I will say this. He said, but Marty, when I was living in the Bronx, I'm 9 years clean. Every day I think of using, and I don't know why I don't. And that begs the question, why wouldn't you use? We always ask, why are you using? Why wouldn't you use? Why wouldn't somebody in Sullivan County who has to walk 7 miles to get an answer, why wouldn't they use? I think I would. All right? So what we need are hearts and minds, and for people to realize it's not as simple, and the paradigm has to shift, because we are in a rural county, and you cannot treat the funding economics like you do the Bronx. We're 61 out of 62, Robert Wood Johnson's health rating indicators, whatever. But the Bronx is a different animal, because that guy who never thought he would die in Sullivan County can get on a bus and get out of the Bronx, and get on a train and get out of the Bronx. Keith has to walk 7 miles, and it's easy to say F it. And I was in a room with him when he was on the phone with medical transportation on hold for 2.5 hours, and he said F it, I'm not waiting. All right? So these are things. So what we need Albany, and I'm pointing you, you're Oasis, but you're not Governor Mario Cuomo, but we need to make people accountable, because we're doing stuff that the funding agencies can't do. All right? And you give us a little, we'll take that dollar, we'll make it go 100. We'll make it go 100. And we won't worry about what's in the budget at the end of the year, because you can guarantee somebody will either got service or got food or got a place to sleep with that dollar.
Can I say something? So I just want to talk about the reciprocal nature of relationships in the community. And I want to give a special shout out to the researchers, Patricia, Katie, and Elizabeth, for coming to our community. I had invited the researchers to come to the federally qualified health center that I helped to start in Sullivan County, that serves the homeless, it serves marginalized communities, farm workers, and the community that is most disorganized is actually part of the constituency that our health center hopes to serve. And we were doing work in the opioid realm. We were doing opioids specifically with pregnant moms who were, trying to get away from the addiction. And I had no idea that the health center was doing this without funding. They were doing this, and they wasn't even being recognized by other providers in the community. That we had researchers here for over a year that had never spoken to the researchers to say, yes, indeed, there is a federally qualified health center that offers this service to pregnant moms on opioids. Very proud to sit here today and tell you that as a result of the conversation that the leadership of the health center had, we now have secured 1 year of funding to work with our pregnant moms, and we hope that that is going to open up a pathway that we can continually be funded. So that reciprocity, whether it's reciprocity between the researcher and a health provider, whether it's between the community and the health provider, we are all in this together. And I feel that if we don't once we lose sight of that and we just get into these turf wars about protecting our funding and protecting our clients, and we don't want, that to happen, that's when it just turns into a real bad scene and we work against each other.
I just have to say, when you just said turf wars, I mean, we were talking about that on the way up. Everyone up here smiling because the last thing I don't think any of us want to do is sit up here and point fingers or be critical. I mean, that's not the point, but you want honest conversation, right? And you want to know how we feel. And that is, in a lot of cases, we can do a lot of great things with my annual gala is a kayak and canoe race every year. We raise like $25,000, and that's our budget. And so, do we need a little funding to, pay for marketing material? All of us are volunteers, but to pay for some marketing materials or, those types of things, absolutely, 100%. But none of the people that are working with us want a paycheck. A thank you would be nice. Wow, you guys are doing great things, and let's work on ways we can all work together would be amazing. And not just saying it, but really meaning it. But the turf war thing, wow, I feel like all of these grants are just what's destroying us. And that's a terrible thing to say, but right or no? I mean, it's like this, everyone is justifying these numbers, and yet...
Well, it creates competition too, because your numbers can't be my numbers because I need my numbers for my grant, and we need you to keep you over here. So yeah, it does create a bit of competition, which is completely opposite of what the whole point of it is, because everybody in here is trying to do good things. And I think kind of to piggyback off of what both of you are saying is we need buy-in to everybody's program. The point of problem solving is identifying the problem, come up with a solution, and then testing the solution. If it doesn't work, that's not bad. We just go back and we find another solution and test that. The problem is if we don't have an answer to the solution, that's unacceptable. So if we have these groups that have solutions to these problems, we all need to support each other in various ways instead of kind of looking at each other going, well, wait a minute, you're kind of close to what I'm doing, so I'm here, you stay over there, we'll deal with it separately. We all need to buy into each other and support each other. And I think that kind of is what's really important.
We have a few minutes left, and I want to hit two questions. And the first one, Marty, is what advice do you have for people in communities across the country who are dealing with this same problem?
I mean, I was an organizer. I am an organizer, not was, so I'm still alive. So for about 40 years, and I started in Bronx, Brooklyn, Appalachia, where I met my wife. I was lucky enough to meet her. And I don't know the answer to that question. I don't know the answer to what I would tell somebody in another community, other than it's your community. It's yours. That the folks who set policy work for you. The folks who dictate what you do really work for you. And that what gets lost along the way is the degree of accountability that is thrust upon folks who are doing the boots on the ground grassroots work. It's that pyramid. You can't have the tip of the pyramid. You don't have the guys at the bottom, selflessly devoting their lives to a greater good. And I do agree with Guy that together we're better. But I would be remiss, I just have to say one thing real quick. A huge problem is the workforce issue in Sullivan County is as epidemic as any substance use disorder. All right? To have peer advisors make 15, 16, peer navigators and peer support specialists make $15 or $16 an hour, work a job overnight to come into work the next day to serve somebody, is like treating the county like it has a $10 head and buying it a $10 helmet. All right? And that is a big problem in Sullivan County across the board. And it needs to be and it has to be addressed. So what I would tell people in a rural community is make sure your workforce has the inputs it needs to provide the activities and the throughputs to get some good feedback and output.
And then I want to end with the question of what are some practical things, what is the low-hanging fruit that Albany can do to move the ball forward for you in your community, to help Sullivan, to help Orange counties and counties across the state?
I'll jump in there because I did a little homework on this. I reached out to a few people and asked for their low-hanging fruit ideas. First, we don't think there's that much low-hanging fruit. Pretty high up on the tree. But one was make sure everyone in the community that's could possibly come in contact with someone who's been using opioids, make sure everyone has Narcan, naloxone, that they're carrying it, that they're trained in it, that no one leaves a rehab leaving treatment without a Narcan kit and knowing how to use it. That was one of the ideas that came forward. Another one was, aftercare. Where are we on aftercare? We have the people leaving rehab and the treatment centers going out into the same communities with the same people that they just bought the drugs with 3 months ago and were using with, and they're going back to that same scenario. How are we helping them to get past that? Because that's the default. They go back. That's a very big temptation. And my own ideas on this are, and Katie touched on this, the doctors are prescribing opioids, but they can't prescribe Suboxone or Sublocade, which is a shot that you can now take instead of those little films that they give you in a box, which they call $10 bills. They're like, go out in the street and get $10 for one of those pretty easily. So that's just, there's something just wrong about that. What about the Hippocratic Oath? You do no harm. You can't, there's only a few doctors in our community and they always have the waiting list. Otherwise, those folks that want to get better, they want to have a way to not go out and use on the street and buy those drugs, and there's no one to serve them. That's got to be, every doctor, we can't let them off the hook. The doctors have got to be on the front lines of this. We say it's a disease, where are the doctors? And secondarily, I called my hospital at noon today just to make sure I was saying the right thing about my hospital in my community. It's pretty much the only hospital in Sullivan County except for the branch in Calhoun, which is very good. If I'm a heroin user, do you have a detox program for me there? First of all, I got no way. There was no one to answer the phone. And then the second, I called back. Hold on. I'll get somebody. They passed me on to somebody else. She also said, hold on. But then the third person to come on the phone said, no, but I will tell you what you should do. Go to the emergency room, and they'll examine you. They'll see what's going on. A doctor will examine you, and you'll either be admitted to this hospital in maybe the mental health floor, or you'll be referred elsewhere, possibly to Bon Secours, Port Jervis, New York State Hospital. Bon Secours has a detox unit. Bon Secours has a short-term rehab that's part of the hospital. But my hospital doesn't have it, and neither does Orange Regional. So how is that allowed? This is an epidemic? U.S. Surgeon General, an epidemic, and the hospitals don't have to provide care?
Yeah, you should be able to walk into any hospital in this country and say, I need help. And you should, if not that, they should lower the criteria to get help, because it's ridiculous how sick people have to be at hospitals. We don't even use hospitals if we can help it. We will definitely try to go straight to a detox and a rehab facility, but we don't have a lot of time when they're sitting there with us and they've asked for help. It's courageous to walk in, especially to a police department, and they say, I want help, and then we're going to send them to a hospital where, in one situation, I actually had someone go to a hospital. They sat there 6.5 hours and left because they were so uncomfortable. That should never happen. And oh, by the way, I should say she was pregnant, which is unbelievable. That was actually our first case. So yeah, 100%.
This is still a thing in Sullivan County. That's a shame.
And roughly 8 years ago, you could go to our hospital, Catskill Regional. There was a detox there, and there was a 14-day rehab program. But now this program, that this problem has grown to the proportions that it is, it no longer exists. That tells me two things. It's possible, but it's decided that it's not going to be done, even though it is possible.
That's a big problem. I just want to continue on the low-hanging fruit, and I although I don't, because I think this is so important. And every time Barbara talks about this, it just makes me want to go chain myself to the boardroom of the hospital over there and not let them leave until they have to step over our bodies.
Okay, next month we'll do that.
Okay, we'll do it. I think part of the low-hanging fruit is the community education piece and helping families have conversations with their children. I know with some of the young people that I've talked to that have been addicted, it was very confusing for them when their family member took them to the emergency room and they, you know, it was their parent that was actually dispensing this to them. And that was a very big conflict for the child. And then the parent lives with the guilt and the parent saying, you know, parents need support, parents need help, parents need some type of feedback or the support that they could say, you know what, give me the extra strength, whatever, in lieu of what you're giving me. Because a sprain or wisdom teeth, many of us have been through this without the opioid accompanying those experiences. I just wish that there was more of a community-wide dialogue happening where the parents can feel comfortable, as comfortable as they possibly can, to talk about these difficult subjects with their children and to trust their gut.
I would say one last thing, and you've touched on education, and I think what goes along with that in almost every issue that we face is prevention. You know, we talk about getting people off opiates and other drugs, but prevention's got to be a huge part of it. You know, in the late 80s, and it might be laughable now because we look back at it to just say no, but it actually worked. Education and prevention can do a big part, and the government can have a big part in that, whether it's local or state or federal. I think educating and middle school kids or whatever age you want to come to an agreement on painkillers are opiates. You know, heroin used to be a painkiller. You know, all these are basically the same types of drugs that have the same types of dangers. Goes along with the education to the community, and I think that it can attack it from both sides of helping people get off and streamlining that process, because it's extremely hard to get people the help they need, but also preventing the addiction from happening by not letting them be addicted in the first place.
So we are 5 minutes over, but I want to give the panelists, I think they're going to stay around for a couple of minutes if you have questions and want to come up and talk to them. I want to give the panelists a big round of applause and everyone who drove out here today for coming, and thank you so much for being here.
Situations, but that leads to a better result. And I thank you all for engaging in that dialogue, and thank you all for coming tonight. Please stick around if you want to ask some questions, and have a great evening and safe trip home. Thank you very much.